Hiya, thanks so much, Rory, and thanks again for UEA for all their amazing help supporting this. I'll just screen share now, hopefully. And I'll start with so I'm Sarah. I'm one of the MedStop team. I'm going to do ABGs today. I'm going to kind of start from I know we've got a mix of different year groups, so I'm going to try kind of start from the basics and then work up, and they're kind of one that you want to be super confident with and you want to feel really comfortable with talking through and knowing, both because when you see them and doing them, you're often doing them on unwell patients. So when there's a FY1, it's kind of not a time that you want to be spending that sort of second longer. You don't want to be using your thought power, and you want to be just kind of feeling comfortable, and that's when you're kind of getting onto your safer ground of knowing what to do. And also because they do often come up in OSCEs. I know in fourth year they often come up in fourth year OSCEs or in later other data interpretation stations. So it's an easy time to shine and show that you've been around and be confident with it, and not find them scary. So that's the plan for today. So first, why do we do an ABG? For those of you who kind of all med students and have to go ask a patient as a med student if you can do one. They're really painful, although less painful as you do more of them. But so we've got to have a good reason for doing it, really. And what information does it give us that we can't get from other things? And that's sort of oxygen and CO2 are kind of two of the main reasons for doing it. And as well as often, if you've got a patient that's deteriorating or is unwell, often it's a quick way of getting lots of information. You can, of course, do a VBG, but that doesn't give you as much about the oxygenation states. And whilst that's are good, we'll look at a few examples later on. They don't always give you the full picture of the oxygenation. And of course, they don't tell you about the CO2. Okay, so when you take it to the machine, this is just a bit what it looks like for anyone's been in clinical practice. I'm going to try to keep this relatively interactive, so feel free to pop in the chat, and we've also got some polls that I'll try use correctly to pop up, and kind of just to try and keep them. I'll try just give 30 seconds or 60 seconds to give those, so you're trying to get a bit more of the pressure situation of either being in an OSCE or in real life. So the first. So I've just put an ABG. I've just kind of interpreted these. They're roughly kind of what you might see, but a bit ad-libbed from what I think, so don't take them too seriously, but just have a look. And I'll launch the first poll now. And if I'll just give you 60 seconds, what is going on here? And just give you 20 more seconds. Okay, I'm gonna stop it there. So great job, both of you. This is type 1 respiratory failure, and kind of just how I would approach this, and one of the things to say as well is there's loads of really good resources on sort of Geeky Medics and other things about how you approach, and people say what to look at first. And I would just say there are good techniques to kind of which to go for, and you might think about pH, but find one that works for you and stick to it, because it does give you lots of information. And as long as you're comfortable going through it, that's okay. And what you want to be picking up really quickly is when you're doing this OSCE is this worrying? What is it that worries you? So I often start with the pH, and I've put in the normal ranges at the bottom, but I'd say pH is one to kind of know off the top, and that pH is okay. So that's immediately a little bit reassuring of what reasons we're doing the ABG. If we're thinking about, is this acidosis, is it alkalosis, we're feeling a bit reassured. Then moving down, but we get to oxygen, and that's worrying. So I'd be looking at this in ABG, and I would be saying, so this is ABG, the pH is maintained, there's no acidosis, but there is a type 1 respiratory failure with a worrying oxygenation level of 7. This patient needs to be started on emergency oxygen or high flow oxygen. So kind of really getting across quickly, because you ask a clinician on the ward kind of what do they look for in OSCEs, and a lot of them sort of say, oh, we just want to know that you've been around, we see that. But what kind of does that mean? I think it means basically knowing that you'll keep someone safe, and also that it looks like ABG is a really quick way to show that you can be around if you're really comfortable and confident in saying kind of like, this is worrying, this isn't, this is what kind of makes the scene. Gives you lots of other information. And just to quickly mention as well, it gives you that oxygen saturation, kind of more for real life. Often you're not sure if you've got a venous, you see a number and you're like, oh, that's worrying, but you want to know, is this actually an ABG sample, or is this a venous blood gas sample, in which case that's a lot less worrying. We don't need to worry about that. And often you should look that the PaO2 should be correlating with your oxygen saturations. So we can see here, we've got worrying oxygen saturations as well. And we've got, gives you also other stuff like quickly you can read off and get your extra information. It gives you your hemoglobin. So we're not worried that this patient is anemic, that couldn't be contributing. And it gives you some other info that we'll talk about as well later. Just kind of to get us started. So owning the numbers, I think, is so important for OSCEs and any data interpretation session. You want to be kind of directly, oxygen's easy, 10 and 8, know them well, be confident, see patients. And when you see a patient on the ward that has this, look at what they're like as it, go see them and kind of link the nation so that numbers mean something to you, and that will come across to any examiner. Okay, type 1 respiratory failure. So kind of all know the symptoms. That's, you know, someone coming in feeling short of breath, they're feeling restless, confused. Often it's very, very scary breathlessness, and drop that in as well to any examiner, because that's how patients feel it. So you've got to kind of manage their anxiety as well. The only other thing is to say that it's not always patients feeling really breathless. Sometimes we can see of type 1 respiratory failure. And I think with COVID, there's a lot of that, of doing an ABG or doing SATs on a patient and then kind of sitting there, seeming okay, and then finding it actually you're surprised by how low they are and how worrying it is. So if you, it while often present like that, not always, and it can be a shock and surprise. And obviously we want to be picking patients up who have low oxygen. So this is what to look for on the ABG of dust and Semarine. It's all about this alveolus gas exchange. So I've done a crib sheet, and I'll give people the slides, actually it'll go on our YouTube, what I use. And so whenever you common stuff with OSCEs, you want to have all your kind of common notes and know them really well. So you want to be able to talk about the mechanism of how it occurs. So we're talking about, if it's type 1, it's a ventilation perfusion mismatch. And you want to know your differential causes. If you know your mechanism, you've got a structure that you can straight away talk about with that. So you can do reduced ventilation, so pulmonary edema is someone in heart failure, or reduced perfusion PE. So those will be some of your normal causes. And then management, often again in the OSCE, if data interpretation or linking it to a REST OSCE station, they'll ask you what would be your management. You kind of want to start with an overarching theme, which is when people often bring in the conservative, medical, surgical, but you can also sort of start with an overarching theme of what is important, what are the management steps to address. And the first thing is to make sure that you're making the right diagnosis. It's really, really important when you know the causes, and we've talked about the causes, that we're making the diagnosis right, because as well as giving someone oxygen and treating them, actually they're going to continue to need that if we're not treating the underlying cause. It's really important to be doing that. And the other thing is that with anyone with rest failure, whenever we're kind of thinking about that pathway, you know, we're thinking about oxygen, when we're thinking about what are our kind of masks, what are our options, then we're sort of going on to more think about NIV, CPAP, BiPAP, and then we're really thinking about, you know, do they need intubating? So it's quite a progression, and not all patients will be suitable for that. So I think it's worth, and it's scary when people go off with rest and get unwell, and can get unwell quite quickly. So we want to know before, what is their escalation plan? What should we be doing that? So that if somebody is starting to deteriorate, but we know they're for escalation, we can be involving the right seniors, because you would be having senior input before often starting someone on an NIV early. So that kind of takes, for when you're on FOIG1, it takes the scariness out of it. And also from your OSCEs, you're showing awareness of this as kind of the pathway. So good to get into the habit as well. I always don't do it, but when we talk about oxygen, talk about prescribing it, because it is a drug, it is something that we're giving people. And we will always talk about target saturations and monitoring the SATs. And look, it's really important to be mentioning this. If it's getting worse, what can we progress to? CPAP or high flow nasal oxygen has been used lots in COVID. And then the underlying cause, just two kind of examples, thinking about PE, apixaban, or if pulmonary edema, furosemide. And also don't forget, if you're in an OSCE setting and you think it's something like pulmonary edema, to mention the stuff that shows you've been around. You know, I would sit the patient up, all of that, throw that in with it, and have a structure, and it really sounds like you've been around, but also in a time pressured way, you can get everything through. And the other thing of linking it to have your remembering your mechanism is that if you're stressed in a situation in real life or in OSCE, you can go back to your mechanism and then do that to work out your causes and your treatment. So that's type 1 respiratory failure. We've now got another ABG, and I'll probably probably given away the clue there. I'm just trying to launch the poll. Yeah. So have a go at this one, and feel free to either answer the poll or grab a piece of paper or say out loud and just be jotting down. If you were seeing this suddenly in OSCE, what would you be saying? What is worrying you about this? I'll just give you 60 seconds for that. And feel free as well, anyway, I can't really see the chat, but feel free to pop anything in the chat as well. Okay, 4 more seconds. We'll pop anything in, go for it, anything's okay. Okay, great job. So good. I know I gave the game away a bit, we're skipping to the sides, but great, most of you right. Type 2 respiratory failure, chronic. And what is it that gives you away that this is chronic? So that's our, feel free to answer in the chat as well. That's our bicarb. So we're looking at this bicarb, and this bicarb is high. So we know that someone is using, had acidosis or had high C2 for a while, so they're starting to compensate with their renal mechanism, which is pushing the bicarb up. So we can see that that is quite high, and you do see it kind of go up to quite high numbers. And this is a bit more steps than the last one, but you guys did great on this, and I'm just kind of really, I know I'm hammering the point in just so you get really confident to be going through it. So pH, looking at this pH, you know, our pH is okay, so this is compensated. That's great. That's immediately slightly reassuring because they're not in that acidosis, and get that across. However, they do have this PCO2 that is worrying, and if we weren't seeing that they were already compensated, just seeing that PCO2, it would worry me. But we're seeing that they've got this high bicarb and they've got this high base X, so they're compensating well. Yeah. So type 2 respiratory failure, what do you look out for the ABG? Yeah, so we want to be seeing, we want to be commenting on the oxygen, on the CO2, and we want to be compensating, even if it's normal, on that we would know that we would be watching out for this acidosis, and we know that it's normal because it's being compensated. And some of the signs of CO2 retention are drowsy, headache, asphyxis, the things you will say when you're doing your examination, though obviously in real life, probably drowsy is what you'll see or look for, or might feel a bounding pulse. Okay, and so then the questions to be asking, is this acute? Is this chronic? Is this acute and chronic? And I would be, whenever I see an ABG, I'd be saying what type of respiratory failure it is, if it compensated, and whether this looks like acute or chronic picture, because then that starts to help to give you your differentials for the next stage, and then how you might manage it. So I've just got 2 up here, and we don't have a poll for this one, but if people, I'll try to get the chat up. And if people want to pop in the chat or not, it's up to you, feeling how brave you're feeling, what is going on in these 2 and what's the difference? Okay, so we've got patient A, we've got patient B. And so we're first kind of looking at it, and we'll start with our pH. And both of these, their pH is worrying. We've got an acidosis. Then we kind of look at their PCO2, and they've both got a raised PCO2. So we know that there's a respiratory cause for this acidosis. We've also got a low oxygenation. So we're looking at a type 2 respiratory failure. And then in patient A and patient B, then we've got a difference when we come to their bicarbs. So we've got this high bicarb like we saw before. And then in patient B, we've got this low bicarb. So this tells us that we've got a chronic, but this patient is not compensated because they've got acidosis. So we've got an acute on chronic picture for type A. And we've got acute on chronic respiratory acidosis with type 2 respiratory failure. This patient probably has an underlying lung condition. Does anyone have any idea what, or wants to shout or guess in the chat what kind of underlying lung condition they might have? And then there's a clue to how we can work that out. So what we want to be looking at is, one of the clues that you can see is there's a carboxyhemoglobin, if you see here, and that's raised. And we don't often talk about looking at the carboxyhemoglobin, but it gives you an idea if someone's a smoker or not, particularly if they've been smoking the last kind of 2 weeks or so. So this is raised. It's normal 0 to 3, I think. I've got it on a later slide, I'll check. But so this is likely to be a chronic smoker with type 2 respiratory failure. We're thinking COPD. Then we go to patient B, and we said that we had this acidosis with this type 2 respiratory failure, but our bicarb is fine and our base excess is low. So we've got someone, this is acute, they're not compensated. So pH, kind of just summary slides, go through, know your range, be really confident with it. And it's an easy range because it's just going from 7.35 to 7.45. Know what contributes to it. So know that you've got your plasma bicarbonate, know that you've got your respiratory system buffering, and that respiratory is going to be what fast acts. So that's why when you get someone who has metabolic acidosis, you can see it in their breathing, because that's kind of fast acting and that allowing compensating. It takes a little bit longer for the renal system to kick in. It can take up to several hours. Okay, so another crib sheet on what type 2 respiratory failure, if it comes up. So differential of causes, again, thinking about what are the types. So airway obstruction, this is your classic COPD, and then asthma, when we're getting to the asthma with exhaustion, when this is life-threatening. If asthma is getting to this stage, it's very, very worrying. They're going to be going to ITU. Reduced strength of respiratory muscles, that's a nice one to chuck in, and that's when we're thinking about our neuromuscular causes. So Guillain-Barré, myasthenia, motor neuron disease, and often it's kind of easy to forget about that as a cause, and these are people with motor neuron disease often using NIV support at night. And the other thing to mention is if anything comes up ever about neuromuscular and reduced strength of respiratory muscles, always be mentioning the FVC from spirometry, because that's going to give you an idea of what level you're going to need to start giving support with the respiratory muscles. And the one people forget is reduced compliance of surrounding structures. I've just underlined as well, which are the two most common, which is COPD and obesity. Obesity is so common. We often forget about the respiratory impact that it has, but it means that your diaphragm and all your muscles and your mechanism of how the clever way that the lungs works less well. So it does cause, and it can cause respiratory failure. And then reduced respiratory drive, like opiates, which we're much better at picking up because they're kind of clear signs that we can see, and we've done it. Again, management, exactly the same as before. If you've got it in your OSCE, take your second to say you want to make the right diagnosis and treat the underlying cause. Make sure you're mentioning your treatment escalation plan and what is appropriate and less appropriate. So prescribing your oxygen, this is when you want to be thinking about what oxygen your range you're going for. So normally if someone is in type 2 respiratory failure, we're thinking of the 88 to 92%, but it can be lower. I wouldn't say that in exams, but just kind of with COVID, there's been some lower ranges as well, but 88 to 92%. And the mechanism for this is complex. It's kind of multifactorial. Used to be think there was an element of relying on the hypoxic drive, but I think actually it's multifactorial, but you can say something like that if you feel you want to. If getting worse, and when we're looking at that patient that we were talking about acute on chronic, we know that they've got underlying lung condition, and actually we might be able to sort of start reversing what's causing the triggering of their cause, but they've got this underlying condition, they're going to be unwell, for a while. And this is when we're thinking about our bi-level positive airway pressure, and I'll go into that in a second. So I think NOV is often a little bit confusing, but actually it all kind of makes sense when we break it down, and it can be a useful thing to chuck in once you know it. And the main focus, really worrying, is if you're getting this acidosis and you want to be helping this clearing of CO2. Okay, a bit on masks. People probably feel quite comfortable with these, but I think it's always worth being super comfortable and dropping in. I would be mentioning, don't just start them on oxygen. What are you prescribing? What type, and what's your mechanism? So nasal cannula, that's your actually is a lot less is more comfy than wearing a mask, but and so if when you see patients on the ward, they'll be on a nasal cannula, but actually it's very drying. So drop in, show that you've been around, that you might want to think about a humidifier or how long they're needing to be on it. Venturi mask, this is what you would be wanting for COPD. This allows you controlled oxygen therapy. You can't just change the dial at the wall, you also need to change what is on and what color you're going for. And blue and white, we don't actually often work up higher than that in COPD because we want this controlled level is what you want to think. And then in COVID, they've been using much higher, like yellow, red and green. And then your non-rebreathe, whenever you're in doubt and you've got an acutely well patient, always start them on hypoxia will kill you first. So start your patient on non-rebreathe and then work to what then do your, once you've got that time to do your controlled oxygen. So feel free to ask them as we go along. And if you want me to speed up and this is stuff you already know, let me know. Or if you want me to slow down at any point, also let me know. Okay, so we said that we mentioned about respiratory support. So I think NOV can be really confusing, and partly it's confusing because people kind of use the NOV term and it's used kind of for lots of different things and it's quite unclear what people mean by it sometimes. So I think it's good to kind of clarify. So BiPAP is in the name, it's bi-level positive airway pressure. Often though, confusingly again, when you're a med student, it's referred to as machine name. So just ask people what it is if it's BiPAP, but NIPI is one of the really common ones. I know that they use in Papworth and ADDIes as well. And the really great thing about BiPAP is you get two things from it. So it allows us to have different air pressure during each of inspiration and expiration. So inspiration pressure helps with deep breaths, as you can imagine. If it's a pressure pushing in, then you can kind of almost imagine you're taking a deep breath. So that aids ventilation. So when we think about what is ventilation, we're taking tidal volume, which if you're taking a deep breath increases, and rest rate. Now I've just put an example so you start kind of familiarizing yourselves what kind of pressures these are, and these are 18 to 24. Then expiratory pressure helps with the removal of CO2. And I always think of this as helping with blowing off your CO2. So that's why it's really, really good in type 2 respiratory failure, because we want to be getting rid of this CO2. This is causing our problems. This is giving us our acidosis. So we really want to be making sure we're getting something that both helps with ventilation and helps with removing CO2. So we've got our oxygenation helping and our CO2. So treatment for type 2 respiratory failure. So that's BiPAP. Any questions about that? Okay, so then CPAP is continuous positive airway pressure. It's a bit like if you imagine if you're driving down a car, pull down your window and stick your head out the window. It's quite uncomfortable when you're breathing out, but it's great so it really helps. It's this constant fixed pressure. So it opens up the airway and it's about 10, the kind of pressure you use. So this is good for type 1 respiratory failure. Doesn't help us with our blowing off CO2. So it isn't good. That's why if someone's in type 2 respiratory failure, you need to be citing them BiPAP, not CPAP. And it's used for type 1 respiratory failure acute, and that's also why it's often very good in pulmonary edema, because you've got this pressure, so you're pushing the water kind of out of the lungs as well, so you're double helping. And it's used in obstructive sleep apnea. Often patients will be using it overnight when they get collapsing, so you've got a positive pressure keeping that airway open. And it's obviously been used loads this year with COVID. Okay, any questions, pop them in the chat. So I assume everyone's good. If you want me to speed up and this isn't new, let me know as well. Okay, so then moving on from type 1 and type 2 respiratory failure, this just chuck this in, even though it doesn't come up as often in real life, it is kind of a classic SPA. Let's just get the poll. Yeah, so just give you 30 seconds to. Yeah, great job. And we'll end it there. So if like this, putting this in, everyone knows it, but is just want to know because they do just chuck it up. And the thing I kind of wanted, why I wanted to put this in, is that actually here we're getting a picture of reassuring sats. So we've got 98%. If you see that, you know, that's absolutely fine. That's what one of our sats would be. But because the sat machine, remember, it can read oxyhemoglobin the same as carboxyhemoglobin. So it gives you this falsely reassuring. So what you really need is an ABG, and they need high flow oxygen. So yeah, you want to be, it shouldn't be happening. We shouldn't be seeing this nowadays, because all boilers should be getting checked at home and be regularly checked. But if it does, remembering that CO has a really high affinity to hemoglobin, so there's this carboxyhemoglobin come in with headaches. You often see multiple people who've been in the same space coming on, or you won't see, but the SBA will be mentioning that. And then there's the kind of classical signs of like cherry red skin, but actually you don't really see that in practice, and you need this ABG and you need to deliver oxygen. So just putting that in as a little reminder. And we talked about this a bit earlier, getting the most out of your ABG. So if someone's got I always check if it should give you the carboxyhemoglobin, and this can kind of let you know if they're smoking, particularly if you're trying to get an accurate smoking history. And hopefully we're all kind of building, making patients feel like they can share what they're smoking, but check that this is kind of corresponding to what they're saying, or whether they do need more support to stop, or whether you think about whether it's not an environment where they feel that they can share that. Okay, so another ABG. What's going on? Give you 10 more seconds. Yeah, so great job. So what we've got going on here is a respiratory alkalosis. So we're looking at this, we're looking at our pH, we're immediately comfortable with our range now. We know 7.35 to 7.45. We're immediately able to say, as soon as we've seen this oscillatory, we're looking at alkalosis. Then we go to our CR2, our PCO2 is low, okay? And we're looking at our PO2. So are we happy that there is something, do we feel happy with this person's respiratory, or is something a bit unusual? So we're seeing our PaO2, so something is going on. So we're looking at a respiratory alkalosis, and we're likely that I'd be wanting to say in this oscillatory that looking at this patient, they'd be likely to be hyperventilating, and that's why we've got a low CO2 coming on. We look at our base excess, then if we're not quite sure, is there a metabolic component as well? But we look at our bicarbonate, and our bicarbonate is range, and we look at our base excess, and that's in range as well. So these are both measures of your metabolic. So we're happy with those. We're happy that we don't have a mixed picture going on here. We've got a respiratory alkalosis. So respiratory alkalosis, we talked about some mechanism, hyperventilation, blowing off your CO2. And I've just put this graph here, bringing it back to your physiology, kind of shows you really clearly that if you really start hyperventilating, you're bringing down your CO2, you will. Causes, common stuff, PE, anxiety, pain, though if you're getting kind of significant alkalosis, be thinking more that, and slash more like if you're seeing a low PO2, that there is something going on like a PE rather than just anxiety and pain. And I put for you to have a full differential in case this ever came up in kind of more of a short answer question, what things you would be considering. But really the common ones we've underlined. And there is renal compensation, but this kind of takes a while to happen. And a lot of these causes, if it is a PE, there isn't time for that renal compensation to come in. Okay, next one. I haven't done a poll for this, but just write down if you saw this, what is your differential for this ABG? Check that I didn't put this in. Yeah, so feel free to write in the chat or oh yeah, and just got a question in the chat. Yeah, so I assume that was about the last one. Yeah, absolutely, it's type 1 respiratory failure. Okay, so what would be your differential for this ABG? What would you be doing? What would be your kind of first sentence that first two sentences that you're saying if you're seeing this in an OSCE? Are you worried? Are you not worried? What is going on? And what is your differential? Is it narrow? Is it broad? Is there lots? And what might be some of the common causes? So we'll start with our pH, like we said. We're feeling confident with our range, so immediately able to say this is an acidosis. And this is quite, we're quite a far off from that. This is a worrying acidosis. We're then looking at our PaO2. It's looking good. I'm not worried about that oxygenation. PCO2, also fine. So it's not worried about respiratory cause at the moment. We move on to our metabolic. Our bicarb is low. Our base excess, low, all filling the same gap. And then we've got this raised anion gap that I'll come to in a second. So we have got a metabolic acidosis. We are not compensated because we're still acidosis, and there's a large range of differentials, and we've got a large anion gaps that allows us to talk about those a bit more. So going on to those. So metabolic cause, look at the pH. You know, you see respiratory numbers all the time, so you hopefully feel most confident with those. Quickly rule out a respiratory cause. Look at your bicarbonate, look at your base excess, and then lose your anion gap to separate out your causes of metabolic acidosis. And the thing to say here is I'm going to go through base excess and anion gap because they can give you extra information, but don't worry, if you prefer to just use bicarb, you can get a really long way just with that, and that's fine. You just keep your differential a bit broad and lose your other information to help you get there. So don't worry at all if you don't get it, just add it in, because I find extra layers kind of helpful, but everyone prefers how they go about it. And knowing your buffering systems, again, like we talked about before. So base excess is in the name, kind of sounds more confusing because we don't use it as often, but just if you're ever having a moment, just think back, okay, it's the level of base excess, exactly what it says, or deficiency of base. So you've got this -2 to +2. So if you've got -2, then, if you're positive, you've got metabolic alkalosis, so we've got a lot of base. That's usually bicarbonate ions, and there's a range of causes for that. And then if we've got a metabolic acidosis, thinking this can either be by too much acid or we've got a loss of the base. And remember that your diarrhea is you losing the base. Then I go to, and so base excess doesn't give us that much extra information than what we're kind of getting with the bicarb, but it's a second thing that's backing you up. Then we go to anion gap. So anion gap can be confusing. Just remember what it is. So it's slightly in the name, so it's anion gap. So it's worked out by looking at the difference between total sodium and potassium ion and the total chlorides and bicarbonate. So that's literally what the equation is. And I just find it useful to remember the equation, both if you ever have to work it out, and also just to kind of keep in your head what actually it is we're talking about. And basically in practice, this means it's basically just a measure of serum ions that aren't measured routinely. So that basically means it's a measure of, it's not these ions that are going wrong. So it's not someone just having diarrhea and are losing these. It means that we've got something else that we're not kind of measuring classically. So that's thinking about, I always think that as being an added, even though it's not an added ion, an added acid into the kind of what we've got going on. So that's things like your lactate, your ketones, or if you've got poisoning. So it's something else. So it's like one of your kind of separate kind of causes. So immediately if you're seeing an anion gap, you're going down that route, and then you want to be scanning down your ABG, looking, because sometimes you often get your lactate and your ketone, looking, is it one of those that gives me my cause, or do I need to think about some of the less common stuff and think about measuring and looking into poisoning? And then low normal, again, that quickly rules out, that shouldn't hopefully be your lactate and your ketones. You'll check those anyway because they're common, but you're thinking about kind of stuff with either your kidneys or your gastrointestinal tract. So that sometimes it can be really hard to diagnose, kind of, or it can almost feel kind of, when you're looking at metabolic acidosis, that's just caused by diarrhea, because you kind of want to be making sure you're ruling out things. That's when you're sort of anion gap can be reassuring and helpful for that. Can also be helpful for tricky stuff like renal tubular acidosis. It all gets a bit confusing, but just chuck it into your section that goes into your head of thinking normal anion gap, metabolic acidosis. That's where I'm putting in my differential. And then also Addison's, and you'd be looking at using your other electrolytes, as we talked about previously, to be confirming that. And then obviously if there's a low, it can be a bit skewed, like lots of blood tests if we've got low albumin. So this is an acronym if you're kind of, what are the things to look for? So uremia, DKA, common, lactic acidosis, common, ethanol glycol, that's antifreeze, poisonings, and then your carbon monoxide, as we talked about earlier as well. It's just mud piles. Don't think you need to know all of these, just have the common ones, but it's a good thing to fall back on. Okay. So I've done a patient A and a patient B. These ones try, it's not a poll, but please do feel free to put in the chat to everyone, or as some of you are doing, just feel free to directly message if that's easier. But there is no getting these wrong, like just getting confident about saying it out loud and going for it. So we've got a patient A, we've got a patient B, and they've got some things in common. So I'll start working it through how I'd approach it. So first of all, we're looking at that pH. That is a worrying pH. We've got an acidosis. Moving on to my respiratory, we're all comfortable with these. This is safe ground in OSCE. We can quickly say, happy with the respiratory is not a respiratory cause, because I've put ones that are very much either metabolic or respiratory, but in practice, it's often you can get mixed variants. And we've also got a low PCO2, so we're starting to get some attempts at respiratory compensation to blow it off and reduce its acidosis, but we're not compensated. We've still got that acidosis. Okay, and then next step, we go to our bicarbonate. We've got a bicarbonate, and this is looking low. So immediately thinking metabolic cause, metabolic acidosis, confirming that with our base excess. And when we're going to our anion gap, this is a raised anion gap. So we're thinking now, what additional kind of acid is there in the blood that is making us have this metabolic acidosis? I'm not thinking just about diarrhea. There's something else that's going on, and it's often these worrying things that we want to be picking up. Okay, so then we scroll down and we think, is there anything more extra information we can get from our ABGs? Let's take patient A first. We've got a metabolic acidosis, we're scrolling down, and then we're coming down and we're seeing this glucose. We've got that glucose is worrying to you. Yeah, so then you say very worrying glucose, very high. What are we thinking? We're thinking this patient has diabetic ketoacidosis. Come on to treatment, how we manage that. These are two of the classics they might give you. Same again in the other one. We already talked about the beginning, the first half, very similar. So we've got metabolic acidosis. Scrolling down, fine with our glucose, and it's good to check that they're not low. Lactate, all worrying, sepsis, lactic acidosis, be starting in your OSCE to be kind of bringing this all together, be saying we've got a metabolic acidosis with a high anion gap. We've got a respiratory, our respiratory function's okay, but we're not managing to compensate for this acidosis needs treatment. And we know the cause. This is lactate acidosis. Okay, and then this is just an example the other way around that shows that you can narrow it down. So again, we've got a metabolic acidosis. This time we've got a normal anion gap. So now we're thinking, and I would be saying, want to be checking causes. So want to be checking if this patient has diarrhea, if they have a stoma. I'd want to be reviewing their input and output chart. If they have checking their renal function, checking their electrolytes, considering stuff like acidosis or renal tubular acidosis. Sorry, Addison's renal tubular. So put this here for you guys, and we'll put this all up for you guys just to learn these: a high anion gap, lactic acidosis, ketoacidosis, renal failure, toxins, and then your normal anion gap stuff, which all gets a bit more complicated, and actually I don't think comes up as often, definitely not in OSCEs, but just to kind of have, if you're ever kind of stuck on a question where they've given you loads of different information, including an ABG, and you're not quite sure what was going on, because some of these things can be harder to pick up. Any questions so far at this point? Okay, happy to move on. So again, as we talked about with oxygen, where you want to own the numbers, show you've been around, what worries you, own the numbers for lactate, what is normal, what is raised, and sepsis is one of the ones really being the big campaign drive to completely recognize, to treat straight away. And really, once you're getting up to levels 8, that's high mortality, probably going to be needing critical care or ITU. So lactic acidosis, most commonly from sepsis. We've got hypoperfusion. You can also get it post-seizure. So sometimes more often done on a VBG, if you're sometimes worrying if this is a seizure or pseudo-seizure, looking at the lactate can sometimes be raised. And then some of the other reasons. The other ones to kind of mention is that you can get this with metformin, makes you high risk of having metabolic acidosis, and these kind of other reasons. These are a lot less common to kind of thinking about our sepsis, and that's the one that they'll want to be hearing you say, but just to kind of build the full picture in your head what it is. You want to be treating the underlying cause. You want to be restoring. It's a sign that the body is not coping, and you're not need to restore oxygenation to tissues. And bicarbonate use depending, but really if it's sepsis you're mentioning here, if you're seeing this in OSCE, your sepsis 6. Okay, the other one we talked about commonly comes up is DKA. I'm sure you're all familiar with DKA. Please put any questions in the chat, but just kind of to go over briefly, if this came up in an ABG like we were doing before, we've got metabolic acidosis with a raised anion gap, and we've got raised ketones, and our glucose is high, so we've got hypoglycemia, ketonemia, and metabolic acidosis, and we will be looking to confirm all those. Everyone happy with kind of how it presents with this first, this polyuria, this weight loss, abdominal pain, it should then make sense why we always see the hyperventilation, because we're trying to get respiratory compensation. So the body's desperately trying to blow off CO2 to try and help with this, but obviously we've got these additional acids. It's not able to do that just by blowing off CO2, so we still are left with our acidosis. But when you see someone with DK, it's a medical emergency, you need to be thinking about treating. You also need to be thinking about what has precipitated this event. So if someone has infection and then they're going to a catabolic anabolic state, then we need to be thinking about treating that infection at the same time. Is it their first presentation, or is there discontinued or insufficient insulin? So something needs to be going on alongside as well, either afterwards once you've treated the emergency of what making sure they're understanding their treatment, and I'd be saying that all in the OSCE as well, adding that in, or looking for precipitating events. Treatment, continuous cardiac monitoring, critical care, and senior input, not output. And then you're thinking of doing your fluid bolus, and you want to be doing that because I've got in the next slide kind of how I think about in kind of OSCEs in terms of what are your priorities of treatment. If you think about what your priorities are, then you can break that down in the treatment. And if someone's got a low blood pressure, as we would if anyone with low pressure, really want to be doing over 50 minutes and just repeating this fluid bolus. This is really worrying. And if they have DK, they're often really severely dehydrated. They might have lost 6 litres. So we're going to need then to be giving fluids more than just little boluses to get our blood pressure up. We need to be really rehydrating. And there's the classic 1 litre over 1 hour, then over 2 hours, and over 2 hours, and over 4 hours, over 4 hours. So it's easy to remember, but there'd always be treatment algorithms as well from your hospital. And starting your fixed rate insulin infusion at 0.1 units per hour. And then, yeah. Okay. So I think I'd feel confident with that, feel confident with it, recognizing it from your ABG, and feel confident with going from your ABG to then how you treat it. And I think because it's so common, it's so serious, you also want to be adding in your kind of detail on your OSCE about how you would treat it. And he talks about priorities for treatment, so I'd be talking about, so really the first thing you need to be starting is correcting this volume depletion. It's really, really severe. Then we need to be worried about the ketogenesis and the acidosis that's resulting because of that. Then we're worried about our hypoglycemia. We're also worried about our electrolyte imbalances as well as our clotting risk. So just kind of address those and mention all of those as well as you go through. Okay. Other really common is renal failure. I'm not going to go into renal failure too much because I'm sure we'll cover it in a different talk if we haven't already, and also because it's a huge topic in itself, but it's obviously a cause of metabolic acidosis. It's not one to miss either, and the patients can be very, very unwell. So thinking about, you can often pick this up with VBGs, but if you picked up on an ABG, that's okay too, but if you're wanting to repeat, see how to do it on VBGs. And your management of your acidosis, it's all your normal AKA management. And then when we're talking about what worries us, if we've got a pH less than 7.2 and we've got this venous bicarb, so it's just about familiarizing yourself with the numbers, less than 16, that's worrying. That's when we're thinking, do we need to kind of be doing more than just treating the underlying cause? Do we need to be giving intravenous sodium bicarbonate to kind of help the body with its compensating for this? Because we've got this added acid, we're going to help them compensate by giving up our bicarb. Problem is, you need to have expert supervision because there's 2 risks, but if they're in AKI, then they're at risk of already, they might be in volume overload, they're at risk of going into it, and your hyponatremia. So this isn't something that an FY1 would be starting this with supervision. And often whenever you're thinking about ITU, you need to be watching for your ionized calcium falling rapidly as well. So if you're mentioning that, mention those in. And then just be familiar with actually, the acidosis in renal failure is so bad that it's one of the indications, and it's for renal replacement therapy. And the other thing is, if you've got severe acidosis volume overload, you're not thinking about giving someone bicarbonate. So we're kind of in a rock and a hard place, and you're going to make their fluid overload worse. So that's when you need to be thinking about renal replacement. You don't have other options. So really the only option is to go to that. Okay, so the last kind of thing to mention is osmolar gap. So we talked a bit about poisoning. This is kind of for undergrad level. I would just kind of remember if they throw in an osmolar gap as well, that means methanol, ethanol, glycol poisoning. So that's someone's drunk antifreeze. Bit of background on it. So they've ingested the ethanol substitute, self-harm, sweet smelling. These are kind of just to keep an eye out for. Doesn't come up hugely commonly, so don't worry if kind of that's all you want to take in, but just for people who want to kind of get the full picture of this raised anion gap, that's what you would also look for, and that kind of confirms it. There aren't many things that cause it. Okay, so that brings us to the end. Anyone feel free to message any questions. I'm happy to re-go over stuff. I hope that was helpful. What I really would say is just really practice it, get really confident on it, and confident on not just saying what it is, but how you present it and what you then link to the mechanism and the management. So that if you're doing this in the OSCEs, it's a great station. You should enjoy it because you should be able to absolutely smash it. And thank you very much for coming. And if you could the feedback as well, that would be really appreciated, because we don't know quite what's useful and what stages people are at. So please do let us know if it's too slow, too quick, or anything would be really helpful. Thank you.
Wonderful. Thanks, Sarah. That was a lot covered there, but it was a really great session as per. So that was really, really useful. I'll just stop the recording.